Recently, there's been some reports of trying to correlate responses to the hypomethylating agents to mutations found in a pathway that involves DNA methylation, TET2, IDH1 and 2, DNA methyltransferase 3A. Is that ready for prime time? Are we ready to be testing for those to decide which patients should get a hypomethylating agent?
Very little of that has actually been published. There was one study a couple of years ago looking at a small number of patients and looking only at a single gene in that particular study. It's something that we're actively working on and actually working towards publishing. But what I can summarize from that data is that surprisingly little can be learned from the genetics. I don't think that you can find a mutation that tells you this patient should never be treated with azacitidine because they will not have a response. That does not exist. Nor is there a mutation that tells you this patient is absolutely going to have a response. We don't have that kind of clarity. It's really more like someone is 30% more likely or 30% less likely based on the mutational data to respond or not. So I'm not sure that it's mature enough yet to use in clinical practice.
I want to highlight and add to what Rafael mentioned about the mutation and the genetics in MDS. We still base our response criteria on morphology, purely morphology. In CML, we moved to cytogenetics and molecular and even deeper molecular testing. In MDS, we still look at the microscope, which is great, but that's it. In MDS patient low risk, where we don't treat sometimes, we watch and wait and we do anything. We observe big series of patients and we've seen they can acquire mutations and that additional events may trigger a treatment at certain time. For example, we've seen in a small subset, they can acquire FLT3-ITD mutation. And that was like immediately after a few months, they had acute myeloid leukemia or high-risk MDS. So eventually, it makes sense, although we need to validate these data in a prospective way, to track them and see whether the acquisition of a new clone, whether it's at the mutation level or karyotype, can predict transformation or more aggressive disease and therefore go for therapy. That is from the monitoring point of view. Now, from the response to a treatment, you mentioned, can we predict response based on mutation disappearing or clone going away? We based on morphology. Actually, we have a presentation at the ASH meeting where we did every 3 months bone marrow on these patients, checking karyotype by G-banding technique 20 metaphases like we do in CML. So what we've seen, even if you have patients who have no response by any criteria morphologically, IWG 2006, you call them not responding. You check the clone. If the clone is disappearing by 50%, for partial response, we define it just, we did it, or a complete response, they double their survival. They can go from 12 months to 24 months surviving based on cytogenetic response, not only criteria of response by morphology. So as a clinician moving forward, I think it's important to track these patients, to have close monitoring at least the first year, whether they are therapy or not, and assess response not only by morphology, but using other tools available.
But it's a complicated story also, because like we also have like presentation, we're looking at the AZA and cytogenetic responses. And even with a complete cytogenetic response to AZA, sometimes you don't see a clear translation to a survival. And this is something maybe me and Rafa had discussed before, that sometimes it's very complex to look at the clonal, or like if you're going to look at the allele burden at diagnosis and follow-up, it's not really a very clear thing because it's not just the therapy that dictates the changes.
Yeah, but I think this is still an important point. The disease is not static under any circumstance, and you're going to have to get used to following patients, not just what are the counts today and how do you feel, but in fact monitoring things molecularly.
And indeed, when we talk about our ultimate trump card against the disease, stem cell transplantation in those patients that are candidates, it's really that issue of monitoring the dynamic disease that is the question. I mean, as I sit with patients who are diagnosed, the concept of transplant is a very complex one in this disease for many reasons. Many patients, even by their age of diagnosis, are marginal candidates. It clearly can be curative, but it clearly can be a therapy that, if with the morbidity and mortality, might shorten the survival of some individuals depending upon when we use it or their approach. So that discussion of is transplantation something now? Is transplantation never because of your comorbidities, your age, what have you? Or is it at some point in the future if something changes? And I'd say for many patients with MDS, particularly those that are at least of a transplantable age, many fall in that category of, well, maybe it's depending upon how you do. Maybe it's the development of a new clinical aspect of phenotype. Maybe it is an evolution of some negative molecular marker that is particularly predictive. Maybe it is how you respond or do not respond to the current therapies that we have. So it is that constellation, plus that final piece that Rami wisely put up. It's a heterogeneous disease, so the patients having a good understanding of the goals of therapy are essential. I've had patients that have shown up to my door who thought that the ESA that they were receiving was somehow a curative therapy, which clearly that was never the intent. So their input in terms of the goals are quite important.